All right, good morning. Welcome to the Grand Rounds. Today it's my full pleasure, obviously, as almost every time around this year, to introduce one of our fellows. We have always three, but he is our star fellow. So the star program is, of course, the Structural Heart Disease program. So, Owais is the star fellow. Yeah. Gotta put that in there quick. Anyway, Owais did a great job. It's almost done. I think we're going to graduate him, so that's also good news. He came from the University of Illinois, right, Chicago, and he's going to go back, but to Advocate Christ, right? Going to do some structural work and interventional work there, continuing his academic career, hopefully somewhat too. And he had the pleasure of going for a little sabbatical here around Christmas time, I think, almost. Yeah, holidays, I should say. And I think you're going to report about valvular heart disease in resource-limited settings, which is the US as well. So.
Can everyone hear me? Yep. Thanks. As Dr. Yessel mentioned, I'm Owais Abdul-Kafi. I'm the Structural and Adult Congenital Fellow this year. And it's my pleasure to present to you this talk. I have no disclosures, and there's going to be a lot of patient information, images that were used with permission. So we're going to review unique aspects of invasive cardiac care, especially interventional care in resource-limited settings and management of cardiovascular and valvular heart disease in these settings. And then I'll briefly go over basic anatomy and technique for percutaneous mitral balloon valvuloplasty. So just an introduction. So global burden of cardiovascular disease, 80% of deaths related to cardiovascular disease happen in lower and middle income countries, as you can see in this map. There's higher rates of smoking, and not necessarily just smoking, but particular exposure, especially as cooking and indoor stoves, higher effects of climate change, less access to medications for chronic conditions, and then dietary contributions, and less diagnostic and interventional equipment available to that we are fortunate to have here, but they may not have in many areas of the world. So you can see this map. This is kind of the global disability adjusted life years per 100,000 population. Ischemic heart disease is definitely the top in most of the countries, and then ischemic stroke is second. But you'll still see that rheumatic heart disease is still up there, even though it's almost eradicated condition, at least here in the US and in Western Europe. So the cardiac cath lab is very important in workup, diagnosis, management of coronary disease, valvular heart disease, cardiomyopathies, and congenital heart disease, peripheral vascular disease, and we're just kind of finding more ways to use this resource here in the US and around the world. But there is a critical shortage of labs in many parts of the world, and this leads to a very large variety of outcomes. So there's a recent study that 59% of patients in South Africa, STEMI patients in South Africa, actually underwent PCI, but in Kenya, only 13%. Can you imagine the vast majority of your STEMI patients don't actually get PCI? And the median distance to a PCI capable center in countries that have a cath lab is like 123 kilometers. Cath labs are expensive. They have a lot of consumable supplies that are expensive, and then local expertise is limited. So I found this very stark picture. This is the cath labs in sub-Saharan Africa. You can see, ideally, you want one lab per million population, but you can see there's this large area in central sub-Saharan Africa that has no cath labs. So these countries, Malawi has 21 million people that has no cath labs. And then there's some countries that have one cath lab, like Madagascar has 31 million population, they have one. And then Tanzania, 66 million people have two cath labs. It's kind of a stark just reality of what's happening. So I was fortunate enough to go with Dr. Johansson to a trip to Kenya in early December. And we went to two sites. One is Mombasa, where we went to the Coast General Teaching Referral Hospital, and then we spent a week there, and then a week in Eldoret, where we went to the Moy Teaching and Referral Hospital. So we'll kind of go over our trip and my experiences there. So this is the Coast General Teaching Hospital. These are some of the staff. This is actually a patient that we treated, and then some of the staff and other members of our team. And this is the Moy Teaching Hospital in Eldoret. And we were there. There were several interventional cardiologists, including Dr. Johansson. The local expertise was limited, so we were going through basics of vascular access, and then also all the way up to all the interventions that we did. So some places like the Moy Hospital doesn't have a operating cath lab, so we're actually using C-arms, which you can see here. And then this is the kind of limited operating room that we were using. The supplies, we brought some supplies over, and they had some supplies that were there from previous trips, but we used Cydex to sterilize the equipment, like the sheaths and balloons and wires and catheters. And that's just one way of trying to maximize use of these tools, these equipment that we have. The patients were all triple screened for HIV, hepatitis B, and hepatitis C as well, for obvious reasons. So we'll talk a little bit about rheumatic heart disease, which is the most common acquired heart disease in children and young adults. So then it's really amazing. There's still 360,000 people dying every year from this, and 50 to 80 million people currently living with rheumatic heart disease. It's one of the leading causes of heart failure in endemic countries. And if you compare non-endemic countries like the US, there's 3.4 cases per 100,000, whereas if you go in some countries around the world, there's more than 400 cases per 100,000. It's also a leading cause of maternal morbidity and mortality, during pregnancy. And then it predominantly affects those in poverty with inadequate access to healthcare. So just very brief, you get infected with strep pyogenes. The immune system makes antibodies against the M protein, which cross-reacts with the proteins in the mitral valve and other valves. And then you get this kind of chronic inflammatory condition that leads to initially mitral regurgitation, then later mitral stenosis, and even affects the aortic valve in some cases. So there are two phases. There's acute rheumatic fever, which is, there's some criteria. There's carditis, which is usually MR or AR, polyarthritis, chorea, which is a delayed, and usually 3-4 months after the initial rheumatic fever, erythema marginatum, and then subcutaneous nodules. Some patients also have fever and acute phase reactants, and you may see a prolonged PR on their EKG. The most common initial cardiac manifestation is MR. And then if you have repeated attacks or untreated, it can lead to rheumatic heart disease, or most commonly mitral stenosis. So here's a girl that actually has the chorea, which I've never seen before. But these are kind of involuntary movements. And sometimes the kids actually get punished because, they can't write very well, or they have, these movements that their parents or their teachers say, oh, you're misbehaving type of thing. But this is an involuntary movement. And these usually go away. Treatment is penicillin, and for secondary prophylaxis, you should have penicillin for long term. If you have no valve damage, but you have rheumatic fever, you treat for 10 years or until the age of 21, whichever is longer. And then if you have residual valve damage, like the majority of the patients that we saw, they treat till the age of 40 at least. Rheumatic mitral stenosis, if you leave it untreated, you heart failure, pulmonary hypertension, and then AFib and stroke. I mean, this is very sad that a lot of patients actually show up because of stroke. And that's usually these are very large strokes. And the vast majority of people who have this and need either ballooning or they need valve replacement for rheumatic heart disease, they don't receive it and they die in their 20s and 30s. And then pregnancy is, with the volume load with pregnancy, it can unmask undiagnosed mitral stenosis. So this the European guidelines, valve mean gradient less than 5, this is considered mild, and then mean gradient greater than 10, and the mitral valve is considered severe. In the American guidelines, you have progressive or severe MS, which is a valve area less than 1.5, and then very severe if the valve is less than 1 centimeter. So here's actually a 19-year-old girl that we saw. This was her echo. I mean, you can see this is like very advanced rheumatic heart disease. You see this, I mean, this is like, you can put this in a textbook, right? The bowing, the flattening of the intraventricular septum. She already has a pericardial effusion. Her PA pressure was more than 100 millimeters of mercury, and her gradient was 22 across her mitral valve. This is kind of very end stage. This is a girl, I did not see her, but Ron saw her in one of the previous trips. She came in with a stroke, and you can see this. You don't need a TE for this. You can just see this massive thrombus in the left atrium. Yeah, and it's kind of layered there. Here's a patient that we saw. You do a TE to do a procedure like a mitral valvuloplasty, and then you see a lot of smoke and probably layering thrombus underneath there. I think this was a 22-year-old at mean gradient of 19 across this valve. So the treatment is closed commissurotomy, was kind of the older way of doing it in patients that had resource limited settings. Open commissurotomy is open heart surgery, and then percutaneous balloon mitral valvuloplasty. So indications for these, typically they have to have symptomatic MS or pulmonary hypertension of the PA pressure more than 50, or atrial fibrillation. And it's preferred that patients that are high risk for surgery or in order to delay surgery to the future. There's actually several studies on very long-term follow-ups. This is one. They had more than 1,500 patients that followed for 15 years. And really only 8% of them needed mitral valve surgery in that 15 years. And 10% needed repeat balloon valvuloplasty. So it's actually a very durable result, especially if you have a young patient in their 20s, maybe early 30s. You don't want to put a valve in them and you don't want them to have open heart surgery then. Maybe you can delay open heart surgery till their late 40s, maybe 50s. The contraindications to these procedures, like especially valvuloplasty or commissurotomy, if you have severe MR to start with, you really shouldn't be doing this. If you have extensive valve calcification, if you have left atrial thrombus, active endocarditis, fixed pulmonary hypertension, although Ron has some cases of severe fixed pulmonary hypertension that actually did benefit. And then if you have a parachute mitral valve, these are more like congenital abnormalities. But in general, like it's best done in pliable valves that are non-calcified, and no calcification or limited calcification in the subvalvular apparatus. So this is the Wilkins score, but it's just basically you get 1 point for, 1, 2, 3, 4 points for each of these categories. But ideally, just in general, you want a very mobile, non-thick, non-calcified valve, ideally with less than moderate MR to get a good result. So here's, this is the cartoon. So mobility, depending on where, which part of the valve is moving. So if you have a 4, that means the valve basically is not moving. If you have a 1, the majority of the anterior leaflet of the valve is moving. Thickening, is it a third of thickening, 2/3, all the way, very thick? Do you have some chordal involvement? And then calcification, how much calcification is there on the valve? The thickening, 3 millimeters or below is considered at 1 point. So here's an example, like this patient, the entire anterior leaflet is moving. It's thick only at the tip, but otherwise the rest of it is pretty thin. There's maybe moderate MR. The chords, although you can't really see it in this view, maybe I'll give it a 1 or a 2. So this is a patient with a low Wilkins score, 4 or 5. Yeah. Okay. So the procedure that this trip we were doing is the percutaneous balloon mitral valvuloplasty. It involves femoral vein access, transeptal puncture. Sometimes we did a septostomy, cross the mitral valve, balloon dilate, and then reassess, and then closure. So this transeptal puncture is very common in structural heart disease. We use it for many, many different devices and procedures that we can do. So, mitral valvuloplasty was like the first procedure that used the transeptal puncture, mitral clip or transcatheter edge-to-edge repair, mitral valve replacement, whether it's a valve-in-valve or just a transcatheter mitral valve replacement, perivalvular leak closure. You can do pulmonary vein isolation or ablation. You can do LAVA ECMO is another reason, and then left atrial appendage occlusion, and there's more coming. There's different sheaths that we can use. These are kind of the tools. Most commonly, we use the SL1 or the Mullins sheath, but these are different curves. And then there's some steerable sheaths as well. And then needles, BRK is the one we were using on this trip, but there's also the radiofrequency ablation, the Baylis needle that we use. SafeSept wire is a wire that helps you cross safely. And then the VersaCross is another kind of all-in-one system that some centers use. Put your wire and sheath in the SVC. You can see in this kind of diagram here. And then you put the needle into the sheath. The needle kind of shapes your sheath. You're still in the SVC, and then you come down. The first drop, you're going to come into the right. You're going to come kind of from the SVC into the right atrium, and then the second drop, usually you'll end up in the fossa. This is kind of a anatomic diagram that shows you. So you're going to drop from the SVC to the RA, and usually you end up in the high fossa, and then you come down. And nowadays we use TEE to guide these procedures. So, you use your bicable view to see how high you are, inferior, superior, and then you use the short axis view to see how far you are from the aortic valve. Aortic valve suggests anterior, and then the other side suggests posterior. And then, you should also think about this three-dimensionally. As you're coming down in the fossa, you actually end up moving more posterior. So you can see as you're coming down, if you start here and you come down, you're actually moving more posterior in relation to the mitral valve. Gentle tenting and forward pressure, and then with the BRK needle, you should cross. There you go. That's crossed. And then if you have difficulty, you can also use cautery on the BRK needle. This is kind of like a poor man's radiofrequency ablation. Location matters. Most mitral procedures, you want to be posterior and then superior to mid in the fossa. And then for left atrial appendage occlusion, you want to be posterior and inferior mid. For pulmonary vein interventions, you want to be anterior mid. Just which procedure you're doing will matter. So the Inouye balloon is the most commonly used balloon for mitral valvuloplasty. It comes in a 12 French sheath. There's a balloon at the tip. There's a 14 French septal dilator that's also part of the kit. It's basically a double balloon with 2 layers, and there's an inflation and venting port. So use this stainless steel kind of stylet or tube to extend the balloon to make it thick and easy enough to cross. And then there's a stylet that you can shape in order to get down into the valve once you're in the left atrium. There's 3 sizes, 26, 28, and 30, and you can put as much or as little contrast in to achieve between 22 to 30 millimeters of diameter balloon. And ideally, you want the patient's height divided by 10 plus 10. That's that's how dilated you want the valve. And then post-dilation evaluation, ideally you want to cut the gradient in half without a significant increase in MR. If the gradient is still not at goal, you can add a couple extra cc's and dilate again. And then we usually evaluate the intra-atrial septum. Usually these are left to right shunts and they heal on their own. And you evaluate for effusion throughout the procedure. So here's actually a 12-year-old boy that we saw. So you can see his gradient is between 18 to 20. His heart rate was a little bit fast on this one. And then this patient, he's 12, but he also has some mild to moderate aortic regurgitation. So the idea from the local cardiologist there, and we agreed with that, is dilate his mitral valve, get him maybe hopefully 10 years or whenever he needs his aortic valve fixed, then he can have double valve surgery at that time. But at least you're not doing it when he's 12, right? This is our team. This is us prepping the balloon. And this is definitely a teaching. I mean, I learned a lot on this trip. This is definitely a teaching setup where you have multiple people, some that are various stages of expertise. And then, you have Dr. Johansson standing in the back, guiding the procedure. This is our echo team. This is one of the local cardiologists there and another local cardiologist, non-invasive cardiologist. And then this is Nancy. She's our echo technologist that came with us on this trip. And then sometimes you have difficulty crossing, so the master has to jump in and, within 2 minutes it's in there.
Shaky hands.
Yeah. This is a video of just showing you here. Let me try playing it again. It's showing you, just notice the position of the balloon. So initially it'll be kind of more kind of medial lateral. It'll go like this. That means you're probably entangled in the cords. And here, let's play it.
I'll just restart now.
So you see how it's tangled in the cords, and then once it's going more towards the apex and back, then you know that you're kind of free of the cords. And you can also see it's on TEE. And then dilate the valve.
I'll just restart now.
So this is the same thing on TEE, just the balloon dilation. Yeah. So after the first balloon, we inflated it to 24 millimeters. You can see we have very little MR. Our mean gradient now is 12. If we started out with 18, we're not there yet. Ideally we want half. And so we decided to add a couple extra cc's, and then we dilated 20 to 26 millimeters. Now our mean gradient is down to 5, which is great. And then this is his echo the next day. You can see that valve definitely is opening. Yeah. Unfortunately, I couldn't get the images because those were done before our trip, and I thought I got them, but I wasn't able to get them to play. But this is our after. And then his mean gradient when he was awake, is 5 to 6. And this is him, and you can see, mostly the lateral commissure is one that split, and you can kind of predict that based on your pre-echo to see, okay, we dilated the valve. This is our mean gradient. What do we think? Do you think we have more space to dilate it again with a bigger balloon? That type of thing. This was another kind of very interesting case. This is a 17-year-old female. This is Eileen. She's an echo tech at Children's Hospital here. And so you can already see, this right ventricle is struggling, on this echo. But you see that the mitral valve actually is working. What's going on? Right? So she actually has congenital pulmonic stenosis. You can see this short axis view that is a really tight pulmonic valve. And you may think, oh, this is a mean gradient at 76. Is this an aortic valve? No, this is like mean gradient at 76 in her pulmonic valve, which is just amazing, right? And she's 17 years old. Her pulmonary pressure is about 110. And so we used a 12 and then a 16 millimeter Tyshak balloon. We got the gradient down to 35. And her pulmonary pressure the next day was 70, which is still very high, but much better than we started. And we did watch her for a couple days in the hospital, make sure she doesn't develop lung perfusion injury, because she's had this longstanding pulmonic stenosis for, and they may develop some perfusion injury after you allow blood flow in. Yeah. So this is all great interventions, but ideally we would want to catch this disease upstream. So there's several screening program guidelines for rheumatic heart disease. The World Health Federation in 2012 and modified in 2019, and then there's a 2023 update. But basically, if you have either an MR jet more than 1.5 centimeters if the child is less than 30 kilograms, or 2 if they're more than 30, and then at least 1 view with 2 consecutive frames, then you have mitral regurgitation. The most common cause of that in endemic countries would be rheumatic heart disease. Or if you have any aortic regurgitation, or if you already see some mitral stenosis, then you know that this is rheumatic heart disease. And then ideally, you can treat them with penicillin upstream to prevent them from developing all these complications. So this, if you see a low-risk patient has thin anterior leaflet, maybe a tiny whiff of mitral regurgitation. If you have some thickening in the aortic valve, this pushes you, and some aortic regurgitation, this pushes you into intermediate risk. And then high risk, you're already starting to see thickening, or you have, moderate to severe mitral regurgitation, then you're at high risk and should be followed more closely. This is an article I found. Basically, there's several different, these guidelines say, oh, you need 2 views or you need 4 views of the mitral valve to make sure that you don't miss mitral stenosis. This is actually a single view, just the peristernal long axis. Single view takes 1.2 minutes per child. And in this study, they actually didn't find any significant rheumatic heart disease that they missed. And this saves a lot of time and resources when you're talking about population-based screening for a lot of people. This is one of the trips that Ron was involved in Cameroon. This is Dr. Cole at HCMC, but this is kind of the setup for a screening program. This was our group in Eldoret. This is Eileen, Dr. Johansson, it's Dr. Goodfellow. He came from Florida on our trip. Yeah. Any questions, concerns? This was very interesting.
Nice job. Good job, nice job.
Yeah, thanks.
Any questions? I have a question, but I won't ask the first question if there's other questions. Yeah, I have a question. So you said what? How many cath labs? 20 in this whole country there or continent?
Oh, yeah.
20?
I think something like that, yeah.
Yeah. How many hospitals do you actually have compared to that could do screening and take care of cardiology patients? Is that much more, or are they all in the same category? Cath lab means also better quality care, or are they actually very good cardiology clinics or hospitals around? They just don't have a cath lab.
Yeah, there are. Like that Moy Teaching Hospital, which they're building a cath lab, and that's the one we were using the C-arm for. They have echo and they have cardiologists there that have many patients. It's just that they don't have a cath lab. So a lot of times they have to send their patients to Nairobi, which is the capital, to get these procedures or invasive studies or something like that. Yeah.
I can project into the room, or I can use the mic. Just to comment on that, because I think it is so important. The distribution of good sites, they're so focal, but most of the population has a clinical nurse or a medical officer with 1 year of training. So a lot of what we do, in addition to this technical thing, in addition to screening, is we'll go to these sites where you'll have 4 or 5 practitioners and get a little handheld echo for them. And prior to the training, someone comes in short of breath, the diagnosis is heart failure, period. Might be pulmonary, might be right-side heart failure, might be left, FREF, valvular constriction, whatever. But once you add in a good clinical exam and some basic point of care ultrasound, which can be a 4 or 5 day training thing with them, they suddenly have the skill sets and know which medications to use and when to potentially refer. Referral is a problem too, because most patients have no insurance and it's just not possible to go to the higher levels without programs like this. If I'm on camera at all, maybe I could borrow your tie.
What I find interesting though is when you say these things, it's not better here either, right? I mean, of course we have better care overall, I get that, right? But if you ask any primary care physician here to do an exam and find out what the reason for shortness of breath is, they don't know either. It's just that they refer and someone pays for the echo, you know, that's much better here. But what you do there, we should do here too.
Agreed.
Thank you for that interesting and insightful talk. But do you have any long-term follow-up on these patients, and what % are women versus men?
I think Ron can answer that, but the long-term follow-up is usually the local cardiology teams there. We're probably 60% women and 40% men, based on my recollection.
Right. In general, it's probably about 85% women to men present with this disease process. And of those 300-some thousand, most of them die in the second or third decade of life associated with childbirth or pregnancy. It's unclear why so many more women have it than men. A lot of good theories that I won't go into at this point. We have long-term follow-up. We have 480 some cases now. And it fits the literature that Owais showed that 10 years later, 70 to 80% of them are doing as well as when you first dilated them. But that requires you to select those with Wilkins scores less than 8. As Paul and I talk about the commissure in short axis view, you have to have one side that splits and ideally both sides splittable. That's not always listed in the Wilkins. That's vital for their long-term benefit. And then only that 20 to 30% need a second procedure valve, et cetera, down the line. So very durable procedure when pre-selected well and when they get on monthly penicillin, so they don't have recurrent inflammatory events. If you take a room full of Ethiopian kids where you have 3% incidence and you give them all strep infections, I don't do these studies, okay? Over time, only that small percent will keep getting the inflammatory process. Most are resistant to it. That is not understood either. So it's really has some genetic markers that aren't discovered as of yet.
Thank you.
Going off of that long-term question, when you're considering some of these regions that have other significant epidemiological burdens like trypanosomiasis or Ebola, how do you plan for those long-term factors when there are so many other things, especially with the women and of childbearing age, that could impact their care?
I think you just do what you can. Yeah. I mean, this definitely is a condition that will lead to significant morbidity and mortality in them. And so you just hope that, just like we do here, we hope they don't get exposed to Ebola, right? But that doesn't change what we do. We have a condition that we can treat.
Thank you so much. That was amazing. I know the work that Dr. Johnson does, and it's just amazing seeing your interventions. As somebody who actually grew up in Ethiopia, seeing rheumatic heart disease firsthand in rural part of Ethiopia, actually, that's the main reason why I went into cardiology fellowship as well. My question is more of like from capacity building part, and also given very high prevalence and incidence of chronic rheumatic heart disease. It's just amazing the interventions that you guys do. How is it transferring the skills and training the locals? I know Dr. Johnson, there's a great work of prevention part from the intervention part. How's training the local docs to do the procedures? I know the TEE part may be a little bit hard skill, and also intervention part may be hard skill. Like, is there any long-term plan in terms of training the locals and having them do the procedures? That way they can reach out to more people.
Yeah, of course. So here you can see this picture. We have Dr. Aquinalo here. He is interventional cardiologist in Eldoret. Okay, that's a center that Dr. Johansson, I think, has been to 4 or 5 times. And each of those times, you know, they select 15 to 25 patients that they do together. So he's very skilled, and he could do this. He's ready to do the procedure on his own. And then Dr. Moazo is an interventional cardiologist in Coast General, which is where this site was. And this was his first time, I believe, being exposed to these procedures. But, you know, comparing him from the beginning of the cases to the end of our trip, you know, he definitely built some skills. And the idea is that Dr. Johansson is going in a couple of weeks to the same 2 sites, and Dr. Moazo will join Dr. Aquinalo when they do all the cases in each of the sites. So they build their own kind of repertoire of expertise. Yeah. So this actually was really interesting to see Dr. Aquinalo. He was the main person doing cases for the majority of our trip, and he's ready to do it on his own. Yeah. That's great.
I would just say it's amazing. Done. I mean, how many trips have you been on now, Ron? I mean, have you gone over?
The question was how many trips? My wife and I have been on about 130 trips in our career. And as some of you know, I've manipulated Hennepin to allow me to work 0.5 time. I did a private practice early and then went to Hennepin, and that allowed us to do that. And I'm still kind of at Hennepin. I'm director of international cardiology, but they don't send me any pesky paychecks. So it's my main clinical job is overseas these days.
I mean, I think what you're doing is amazing. I think certainly from a resource, and the question from the back, you know, it's a very teachable skill. What you're doing, everything you show, it's catheters can always be intimidating, but they're all teachable. It's straightforward technology. It's readily available. It's been around for decades. And what you're doing out there and educating the people to do this procedure, I think it's really commendable. So congratulations.
And just so I have a chance to do it, our thanks to Abbott, the structural department. You know, I think they get a star, but I think people that make fantastic diagnoses with stethoscopes do also. But I know what you mean exactly. So we get structural fellows from you guys, from Mayo, etc., and that really adds some good stuff to the program. You know, with Owais saying, "Hey, do you think we can do this?" He says, "Sure." Well, okay, that strengthens everybody. Thanks, guys.
Yeah, of course. Thanks, Dr. Johansson. Thanks, everyone.